This week on the podcast, I wanted to share with you a lecture from a course that Mike Macias of the POCUS Atlas and I put together quite some time ago, actually back in November. This is Sound and Surf 2021. We had some amazing faculty there, some amazing lecturers. I got to meet a lot of really interesting people from a really broad swath of specialties within medicine. It was kind of refreshing that while we did have predominantly emergency medicine physicians there, we had some cardiologists, we had some intensivists, primary care docs, anesthesiologists. We were all there to learn the same thing, and that is how to get better at bedside ultrasound. Here is our faculty list. We just had an amazing time just learning from each other and being able to talk about cases where it works well for us. Now, I wanted to let you know that we finally have settled on a date for Sound and Surf 2022. It will be November 9th through the 11th here in my new hometown of Southern California, San Diego specifically. Now, if you go to the website, soundandsurf.com, you can join the wait list so that once we actually open up registration, you can go to it. For this week's podcast, what I want to do is share with you one of my lectures, top 5 tips for advanced echo. This is not by any means supposed to be a comprehensive look at any of the things that I talk about, but it's just a simple way that you might be able to use it quickly and at the bedside. Don't forget to check out courses.coreultrasound.com for all of your online educational needs, including our fundamentals and question bank course, which is great for learners as a longitudinal curriculum. Our question bank specifically has 3,200 pathology questions that you can go through. And if you happen to be in charge of education at your shop, such as a residency or ultrasound director, what you can do is you can actually track the progress of your residents as they go through the questions to see what they need help on and what they're excelling at. Now, without further ado, on to the podcast.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
All right, so we have Jacob Avila of Core Ultrasound, and also one of my colleagues for our residency UHS SoCal MEC in Temecula Valley.
Yay.
And Jacob's going to be talking about 5 tips to up your echo game today, or actually 5 tips for advanced echo.
Yeah. Thanks.
Okay.
Yeah, thank you. If anybody has any questions or thoughts, especially the cardiologists and intensivists, I'm excited to hear everybody's perspectives on this. This is kind of my level 2, level 3 kind of echo that I do on patients in the emergency department. This is not things that I'm doing on every single one of my patients, but all of the machines that we have here, we tested them, we can do all of the things I talk about on those machines. Even if you don't use it, it's a good idea to understand that you can and know that it's a thing that you can look up to do for that time, which it might be useful. I have a jigsaw at home. I bought it in med school. I've used it twice. But those 2 times that I've used it, that's been the best tool for that specific job. And that's how I think about these more advanced echo things. I'm not going to use them on everybody, but on some patients, it's the most useful thing to do with those patients. A couple of disclosures, Butterfly. I have Core Ultrasound website. I offer some CME content on there, and in the past have done independent consultant work for both GE and VAVE. These are the things we're going to talk about. Start with valves, talk about some easy diastology. I think that can be a little bit intimidating for some people, but know that it's actually pretty easy to do, especially when you think about it binarily, which is what I do. We're going to talk about the RVOT morphology in the setting of acute versus chronic right heart enlargement, regional wall motion abnormalities, and then spend some time talking about cardiac arrest patients. Let's start off with valves. Now, what I'm not going to do is I'm not going to talk about the grading of regurgitation or stenosis, because that is like a whole long talk and there's a lot of nuance and stuff. So we're just going to talk about real simple stuff. The first thing is just looking at the 2-dimensional evaluation, looking at the leaflets themselves to see if they're coapting well, to see if there's any bad stenosis, looking for vegetations on those lesions. And then we're going to talk about using color Doppler to basically look for regurgitant flow specifically. You can definitely use your color Doppler to look for stenosis as well, but I'm just going to talk about it for regurgitation because I think that's the easiest. First thing is coaptation. The coaptation is basically how well the valves are coming together, and what you want to see is you want to see the valves create like just a little peak. That's what you want them to create. You want them to kind of touch. So over here, my tricuspid valve, they're making a little kind of peak right there. Same thing with the mitral valve, a little peak right there. That is good. That is normal coaptation. Here are a couple of examples of poor coaptation, which if you see poor coaptation, that should clue you into the fact that the patient probably has some massive regurgitation happening because the valves aren't closing right. This was a patient that ended up having endocarditis on this leaflet right here, and you can see that it's not creating this nice peak. This was kind of going underneath this one, and then same thing over here. This one is up top, this one's below. They're kind of overlapping. This would create big regurgitant lesions. These are one of the first things that I look for. The next thing I look for on the two-dimensional evaluation is going to be the evaluation of stenosis. On the left hand, we have great excursion here. This mitral valve is opening up very nicely. The aortic valve here is opening up very nicely. And on this side, we have not those things. Now, if we look at the overall ejection fraction of the chamber right here, it's not too bad. Like, it's a little diminished, but it's not too bad. Pretty thickened walls over here as well. But if we look at the mitral valve here, barely opening up. If we look at this aortic valve, barely opening up as well. So it's pretty easy to say, kind of binary, yeah, I think there's some stenosis or not, based off of how well those are opening up. So a couple more examples. This is pretty bad mitral stenosis right here, seen on, tricuspid stenosis, seen on an apical 4-chamber view. This one I've actually only seen a couple of times because this is not super common for us, but this is a rheumatic heart disease causing that kind of hockey stick appearance of that mitral valve. Pretty rare, but we see it. Here's another example here. This is a good example of aortic stenosis. So if you see here the mitral valve, it's going up and it's hitting that, it's very nearly hitting that septum. We have good excursion here. We probably have some diastolic dysfunction here based off of how thick the walls are and how big that left atrium is. But we'll look at this, good excursion. We look here, very poor excursion. The one kind of grading thing that I do like to talk about is just with severe aortic stenosis. I have a lot of elderly patients that come in with pre-syncope or syncope, right? And when I see this, and I see this pretty commonly, like a little bit of calcification on the valve, there's calcification with some shadowing. I see this fairly frequently, and my question is this stenosis, which I feel like all people past the age of like 80 have a little bit of stenosis probably, you know? Is this stenosis the reason why they syncopize, right? So what you do for this, and this is the one calculation that I usually do with aortic stenosis specifically, because that's kind of like the critical one. You get an apical 5-chamber view, so over here, it's not a great apical 5-chamber view, but apical 5-chamber view, and then you throw continuous wave Doppler through there, and all you're doing is you want to know what the peak velocity is through that valve. Now, you know when you pinch a hose, it shoots out super fast, right? You can actually detect that with aortic stenosis. If that number is greater than 5 centimeters per second, that is a patient that has critical stenosis. So that's like the one number I'm looking for. Is it greater than 5? If it's greater than 5, I'm much more likely to think that this aortic stenosis was actually a cause. So it's just one calculation, continuous wave Doppler. To me, it's accessible enough for me to do it on most of my patients that I see this pathology in. Moving on to vegetations, I have a whole series of slides where I have veggies on every single valve. I love it. But basically, if you see any kind of a mass on a valve, this is tricuspid mass right here, think about endocarditis. I don't see it as much at New Job, but at Old Job in Kentucky, we had a lot of people that did IV heroin, and we would see this on the tricuspid valve a lot, like almost invariably. One of the views that works really well if you want to evaluate the valve on the right heart is actually the RV inflow view, which we can work on the models. It's basically a parasternal view, and you just angle the tail towards the body and the beam a little more anterior, and you get a great view of just the right atrium, the tricuspid valve, and the right ventricle. So a good view to look for if you're not able to get a good apical 4-chamber view. Just look for those vegetations. Lastly, we're going to talk about regurg. It's pretty easy. You just throw color flow on there and you just see is flow going the wrong direction. Now this right here, I usually edit all the extra stuff out, but I'm going to leave these in here for the evaluation of regurgitation, because all you want to do is you want to know, is the blood moving in the wrong direction? And the way you know that is by looking at this. So blood should be moving from the atria to the ventricles, right? So blood should be red going up into the ventricle. If you see blue, that's going away from the transducer, which means that blood is moving this direction, and it is a regurgitant jet. So this is a little bit of mitral regurgitation right here, a little bit. Now I will say with the gait, I usually angle the gate a little more into the atrium to see more how the flow is moving around. This little kind of, you see that little arc dome thing right there? That's actually something that you can measure. The PISA method to help you figure out exactly what level of regurgitation that is, just if you ever want to go like step like 7 to figure that out. But for the most part, I'm putting this just in the ventricle to see how big that flow is. There's a bunch of different ways to measure the intensity of that regurgitant jet. But I'm going to be honest with you, most of the time, all I'm looking at is it a lot or is it a little bit? That's basically the two things that I'm at, or the one thing that I'm asking myself because I'm just a simple ER doctor. So the other one was a little bit. This is more, right? All of this coming back as a massive regurgitant jet. You can also look for mitral regurg with a parasternal long axis view. You can see it pretty good here, and you can see that it is actually concentric, kind of wrapping around. And when it wraps around like that, it's more indicative of a more severe regurgitant lesion. The one thing you have to be careful with is you always want to make sure that your Doppler angle, so the angle from here to the jet that you're looking at, is not a perfect perpendicular. It's not like 90 degrees. Because if the beam is 90 degrees to something that's moving, you won't get any signal back. It's like a physics, trigonometry, math thing. I don't really know how it works. You have to be at a little bit of an angle. So if you're doing an a parasternal long axis view, and you're not really getting a good color view, just tilt your transducer so that the angle of flow is not 90 degrees. So see how it's a bit tilted? It's not 90 degrees to the angle of that transducer. Here is a example apical 4-chamber view. It's not a great view, but we're still able to see this regurgitant jet. So the blue coming down, the little snake coming down, is flow through the LVOT into the aorta, and that kind of red flame that's coming back out, that's some significant aortic regurg. It's almost filling that entire route right there. It's a little more significant. Here is a small bit of aortic regurg. So this is flow out, which you're supposed to see in that little blue flame coming back, as blue is going away from the transducer. This is going away from the transducer. This is a little tiny regurgitant jet. Right here, we're seeing a very tiny bit of tricuspid regurgitation. You guys see that blue line right there? That is a little bit of tricuspid regurg. A little more severe here. It's even concentric. You can see it kind of wrapping around all the way up like this. So be more severe. Now remember that I told you that the width of that regurg jet is really all I use to tell if it's bad or not. The one caveat to that is in patients that have really enlarged right sides of their hearts, their right heart can get so big that if we look at this regurg jet relative to the size of the right atrium, it doesn't look that bad. But this is actually just like a hollow systolic, like the valve just, it doesn't even work. It's completely like, doesn't work at all. But because this right atrium is so big, it's not filling up all the way. So with this, you actually, if you want to measure the actual intensity of it, you actually measure the area of that regurg jet to see, especially when it's that enlarged. One of my favorite things to look at more recently is the RVOT, because it's something that can actually be pretty helpful. This is a high parasternal short axis view. This is the aortic valve in cross section. This right here is a tricuspid valve. This right here is the pulmonic valve. And you can actually look for pulmonic regurg by putting your color Doppler gate on that area. You guys see that little tiny red flame? It's just a little bit of pulmonic regurg right there. Any questions on valves before we move on? Yes, sir.
The parasternal long axis. Which side is which? So the color, I mean, in the apical it's clear that the one toward the probe would be red, and then away from the probe is blue.
So we'll take this, like this one right here. So it's a little tricky, but you just got to think about it as far as flow with what's happening relative to this, right? So let's pretend, or not pretend, this is the angle, right? Anything moving towards the transducer is going to be red. Anything moving away from the transducer is going to be blue. So imagine a perfectly perpendicular line right here, perfectly perpendicular, right? You can see that this blue flame right here, if there's a perfectly perpendicular line, is actually a negative deflection flame. So this is going away from the transducer, so it would be blue. So that's usually what I do. I don't remember like blue away or red towards. I just always just look at this and say, okay, this flame right here that looks like it's going this direction, this is a negative deflection, this is going negative away from the transducer. Blood should be moving this way. That means this is a regurgitant jet because it's moving the wrong way from blood based off of like whatever, if it's below that line or above that line. It's not always going to be like perfect like down and perfect up. The best signal that you get will be perfect down and perfect up. That's why most of the time we're using apical 4 chambers to look at the mitral and tricuspid valves. But sometimes the peritoneal lung is the only view you can get, right? So it's a good idea to just kind of like understand that concept. Great question. Yes, sir.
What would you do for aortic stenosis if somebody had like 10 to 15% of that? Do you have like a method for trying to grade their aortic stenosis in that situation?
Yeah, so his question is what if they just aren't generating enough flow to get that high? There's other things that you can look for here besides it. You can look at the gradient. There's a lot of physics-y things. One of the things too is if you look, so look before the aortic valve, you actually can measure the volume of the area before the aortic valve and then measure it at the aortic valve. That should be equal, so you can actually measure the area that way and figure that out. And then you can also look at the overall valve area, but that gets into like the stuff that we learn for echo boards, not stuff that like I can teach within like a short period of time. But there's these 3 things that you can use on top of clinical exam and all that stuff to figure it out. And it's not like you have to have all of them. It's basically I pick and choose which one works. And for me, the easiest one by far is looking at the aortic velocity. But that's actually a good point. Like if they're not generating, their cardiac output is like super duper low, they might not generate that 5 centimeters per second, even though they have severe stenosis. And in that case, you do like a lot more annoying and time consuming calculations that way. Yeah, I can share, there's a great ASC article that like walks you throughout all of it in a very good manner. I can share it with you afterwards. Yes, sir.
In the same slide, the continuous double flow should be above the valve or just past the valve?
Great question. So his question was the diamond of the continuous wave Doppler, where does it need to go, above or below? So pulse wave Doppler is the only one where the gate needs to be in a certain place. The continuous wave Doppler is actually measuring all the velocities along that line. So the diamond itself actually doesn't matter necessarily. You just got to make sure the line is going in the middle of the flow. You want it to be right in the laminar flow kind of area. Great question. Any other questions?
The pulse gates right before the valve opens, I guess. Like if you're doing the pulse wave Doppler. But I guess with like continuous, it wouldn't pick up really high velocities if you're doing the pulse wave. So that's why you use it continuous.
Yeah, the continuous one it's better at higher velocities. So that's why like if you have a high velocity system, it's usually better to use that continuous wave Doppler. Yeah. Excellent. All right, let's move on to some easy diastology. Now, with diastology, what you want to do is you want to get your apical 4-chamber view. This might be a result for review for some of you. You get your apical 4-chamber view, and on this one, you're actually going to use your pulse wave Doppler on this one, and you want to place these just inside of the mitral valve to get your first calculations. You hit your PW button again, and you get a waveform that looks like this. Now, before I did ultrasound, like when I was a med student moving into residency, I had no idea that the mitral valve actually like opens twice in the cardiac cycle. Nobody told me that, but it opens twice. You have an E, well, flutters, I guess. You have an E wave up here. This is your first one, and then you have an A wave down here. And you can actually use both of those to calculate if they have diastolic dysfunction and then what grade of diastolic dysfunction they have. This is half of the calculation. The second half is another pulse wave Doppler. What you want to do actually is change the setting of your ultrasound machine to do tissue Doppler imaging, TDI, because it changes the scale. These are pretty high velocities, and if you're measuring the movement of the tissue, those are really low velocities. So it just automatically changes the scale so you can measure the tissue velocity next. You can place this either on the lateral annulus or on the medial annulus. There's discussion as to which one is best. For me, it's whichever one I get the most crispest view, that's usually the one that I'm using. I usually end up using the medial one. And you get a very similar waveform, right? You have your E wave right here, and you have your A wave over there, but they're just gonna be opposite directions because the heart muscle moves in the opposite direction than the blood flow is moving. So that's why it's a negative deflection. But your first one is still gonna be your E, your second one's still gonna be your A. We label these as a lowercase e with a tick mark on it. We call it E prime and A prime to separate it from the mitral inflow velocities. And then just for fun, this, just so you know, this is called an S wave. Now this is kind of the old school way of how to like grade it, just based off of morphology to know if it's grade 1, grade 2, grade 3, or grade 3. There's also grades past that, but we just focus in on that grade 3. The most recent ASE guideline, which is the American Society of Echocardiography, which is how I learn all of this stuff, is this. Now, this is actually a simplified approach compared to their previous one. And I'll tell you guys, like, if you have like an extra hour to spend just echoing your patients, this is like fun stuff to calculate. Like, I actually enjoy it. You can calculate this septal E prime or the lateral E prime, calculate this ratio. You can check your tricuspid regurg velocity if it's greater than 2.8. That puts them in a certain category. And this is the left atrial volume index, which is pretty sweet also. It's kind of fun to calculate because you use that based off of their weight also. And then if it's greater than 50% positive, then you can start putting them into these categories. If it's less than 50%, they're positive. And then if it's half of them are positive, then it's indeterminate, which is kind of interesting because sometimes I can't get all of these. So if you can't get all of these, you can't really like do this calculations. And the ASA people actually like, they admit that. They're like, this isn't perfect, but this is like the best we can do. This is like a lot of work. And I said, like, do you have an extra hour? It literally takes me like 45 minutes all said and done to do all this stuff. And I'll do it if I want to, but the simple ER doctor in me only wants to know this, really. I don't care what the grade is. I just want to know, do they have elevated left atrial pressure? Is their diastolic dysfunction the cause of their dyspnea today? That's ultimately what matters to us in the critical care or in the emergency department setting. And the way that we can figure that out is just using the E to E prime ratio. We can figure that out. So this is my algorithm for how I evaluate patients with suspected diastolic dysfunction. So I look first, talk to the patient if I can, do my history, and figure out, do I have suspicion of this patient having heart failure, okay? If they don't have heart failure, then I don't care, right? If they do have I do think they have heart failure, I'm gonna look at the lungs actually first. The first thing I do, right? Because even someone who's got an EF of 20, that's not necessarily why they're short of breath in your emergency department, right? They could have an EF of 20 and then have anemia or have sepsis, right? So I actually start with the lungs. I start with the lungs, and if they have bilateral B lines everywhere, then I'm thinking that's probably heart failure, right? And then if they don't, then I'm going down a different algorithm. Now, after I do the lung ultrasound, then I look at the heart. If they have a low ejection fraction, I'm done. They have systolic heart failure. If they have a normal or a high EF, then I'm going to do this. I'm going to evaluate for that diastolic dysfunction and that elevated left atrial pressure. Now I do that by doing the E to E prime ratio. So that's, you do your mitral inflow velocity with your tissue Doppler imaging, the first peak on both of those, and you look for those, put the big E over the little e, and see what number you get. If that number is less than 8, it's not elevated. That's not their problem. Maybe they have COVID, maybe they have ARDS from another reason, because they had those bilateral B lines. If they have greater than 15 as a ratio, it's probably diastolic dysfunction. Remember, a lot of textbooks, I don't know if this is like true in my clinical practice, but a lot of textbooks say that half of patients with heart failure have diastolic heart failure. So this is potentially very common. If they're in the middle, so they're between 8 to 15, that's kind of a gray area, and there's a couple of extra things that you can do. You can look at the left atrial volume. History is probably usually what I'm doing, is I'm probably just being like, it's in the middle, but I have a high suspicion that they have a diastolic dysfunction component. You can also obviously look at the BMP, but sometimes it's a data point that doesn't help you that much, and that's actually perfectly okay, right? Any questions on that? Easy diastology? I feel like I kind of went through it pretty quickly, but any questions? Excellent, all right. So let's move on to RVOT morphology. This is something that has come up recently, relatively recently, like the last 5 years or so. This is something that these cardiologists have been keeping from us, all right? Like, they knew about this for a long time, and we just discovered this in EM 5 years ago. So the problem is you have an elderly patient that's been smoking their whole life, they work in coal mines, they have chronic RV enlargement, they come in acutely short of breath. Is that right heart enlargement, is it acute? Or is it chronic? Is it just like they just have right heart enlargement, but they also have, a cold or something like that? Or do they have COPD and they also now have a pulmonary embolism? There's a lot of different tricks that you can do. Probably the easiest one is to look at McConnell's sign, right? Just looking for that apical hyperkinesis with that lateral RV free wall hypokinesis. There's also something called the 60-60 sign, which is, it takes actually a while to do, so I don't always do it. But it's actually, half of that is actually using this RVOT morphology. And there's a few other things, but this to me is pretty easy and accessible, and it takes no calculations. You don't have to measure any, you measure something, but you're just looking at a waveform. So what you do is you get this high parasternal view where you can see the tricuspid valve, you can see the pulmonic valve, and you're focusing obviously on this area right here. You place your pulse wave Doppler gate just on the outside or distal to that pulmonic valve, and you're looking for something called early systolic notching. It's pretty sweet. I've actually seen this on acute PE patients a few times. In a normal patient, it should look like this, a relatively quick spike up with an easy downgrade, just like a kind of a shark fin looking thing. This is normal. This right here is early systolic notching. So you see a notch, and the early systolic notching by definition is in the first 50% of all of systole for that pulmonic valve. So if you see it in the first half, which we're seeing it here, this little notch right there, little notch right there, little notch right there, that should increase your suspicion that the patient's process today is an acute right heart process rather than a chronic right heart process. No calculations, just is that notch in the first half or not? Let's talk about wall motion abnormalities, which I like. Now, here's the thing with wall motion abnormalities. One of the big discussions that I have is what is the point of this, right? The ultrasound is not the only thing that I use. I have an EKG, I have troponin. So what would be the reasoning for doing this? The ultrasound will show the regional wall motion abnormalities before you see ST elevation or ST depression on your EKG. So you'll see those when the patient just has those hyperacute T waves, which is the first part of that EKG in an MI. So if somebody starts having chest pain, they somehow were like in the parking lot of the ER, they come in, they have a weird EKG, but you see regional wall motion abnormalities, that would be enough to get your cardiologist on the phone. The second thing is it's kind of hard to get an EKG when you're doing chest compressions, right? But you can actually do this calculation during chest compressions. It can be a little tricky, but you can definitely do it during chest compressions, and you can do it during the pulse check. You can't get an EKG in 10 seconds, but you can definitely get a decent echo within those 10 seconds to be able to diagnose somebody with an MI. Now, the big thing with regional wall motion abnormalities, for me anyways, you guys are probably have no problem with this compared to how I was, but it was hard for me to conceptualize what exactly a regional wall motion abnormality was. So it's not movement of the wall that we're looking for. We're looking for getting skinnier and bigger of a specific segment of the wall. You're looking for contraction of the wall of those ventricles, right? So if we look over here, you see how it's getting fatter and skinnier, all the way around. We lost the apex here. Up here, the septum, it's getting bigger and smaller. This is great contraction of the ventricular walls. Now, let's compare this guy to this guy over here. So looking at it right off the bat, it looks like it's a low EF, right? I want you to focus first on this right here. So this is the septal wall. You see how it's getting bigger and smaller? You might have to focus on it a little bit, but it is changing its diameter. Now I want you to compare this wall over here. There is no change in diameter. That wall is moving a little bit. It's like it's moving, right? But there is no change in diameter. This is a regional wall motion abnormality down here, which could either be the circumflex or the RCA. This right here is something that we have on our website. My friend Ben made it, and basically shows the distributions, but you can just kind of think about them as where they are, where the blood vessels of the heart should go to be able to estimate where that regional wall motion abnormality is, where that MI is. All right, let's do a quiz. Okay, you guys got this picture? Makes sense? All right, what about this guy? What kind of an MI does this guy have? So what I like to do is I honestly, because this is easiest for me, I look at this first. Do you think that this section right here is contracting? A little bit, but it's contracting, right? It's moving. Okay, now look out here. This is circumflex. I'm seeing some contraction there. Now focus on the LAD. It's moving, but it's significantly more hypokinetic relative to the circumflex and the right side over here, the RCA over here. So this is a big old, and this is this patient's EKG, a big old LAD lesion, right? All right. Last topic is going to be arrest. Now, I actually have a whole hour-long lecture on arrest because I really enjoy arrest. The big thing that you really need to focus on is the fact that when someone says that ultrasound delays pulse checks, it's completely false. It's completely wrong. Ultrasound does not delay pulse checks. That would be like me tripping over here and saying it's because I put this here. That made me trip over there, right? I tripped because I'm clumsy and I wasn't paying attention, right? There are studies that show that ultrasound is associated with delays in pulse checks. But here's the thing, in what universe is 10 seconds longer than 10 seconds, right? 10 seconds is always 10 seconds. If you are using your ultrasound to prolong pulse checks, you are delaying pulse checks. It's not the machine. The machine doesn't do anything you don't tell it to do as a clinician. When I'm using ultrasound, my flow during arrest is 15 seconds before pulse checks. I am charging the defibrillator. I'm putting gel on my transducer. The pulse check happens. I have the person running the time count down from 10. I try my best to get a view. At 8 seconds, I remove my transducer, I wipe off the gel, and I resume compressions. That is the best way to make sure that you're not accidentally, you as a provider, prolonging your pulse check, right? And you can actually record images. I think it was one of Arun's colleagues, or it might have been Arun himself, has a CASA protocol that they publish, which is great because it separates the acquiring the ultrasound images from interpreting the ultrasound images. So basically what they suggest is doing your ultrasound, recording the clip during pulse check, removing your ultrasound, wiping the gel off, and then while they're continuing pulse check or chest compressions, then they're reviewing the images to see if they see a reversible cause, which I think is brilliant to do that. So just be cognizant of that. There are 3 different ways that I use ultrasound in arrest, and it's procedural, identifying reversible causes, and then actually during those pulse checks. So this is the first one. It's pretty accessible. You know, you got the worst mnemonic of all time, the H's and T's, right? Out of these, there are a few that ultrasound actually does really good at. This is not them. I mean, you can't really check for toxins with your ultrasound, right? But these ones all have really good characteristics for ultrasound. Ultrasound's pretty accurate for them. So these are the things that you want to consider for using your ultrasound to identify those reversible causes. For procedural guidance, obviously the big one here is the removal of that fluid around that heart causing tamponade. There are 3 different locations, or 3 different basically like regions that you look at the heart, and you can do a pericardiocentesis in all of them. But this one's probably my least favorite over here, the subxiphoid. The reason why is because the subxiphoid is probably the safest one if you're doing it completely blind, right? But you are going through liver, you're going through diaphragm to maybe get to the heart when you're going underneath there. Whereas if you go apical or peristernal for your view, you're not gonna poke anything but that pericardium, as long as you got good visualization, obviously. If you can see the pericardial effusion, there is no lung between the skin and that heart, right? Because if there was lung in between, you wouldn't be able to see it because lung blocks sound waves. So next time you have a patient that you're evaluating for a pericardial effusion or pericardiocentesis, look at your peristernal lung, look at your apical 4. This is an apical 4-chamber view with that curvilinear transducer up here, which that's the other thing. You don't use your phase array transducer for procedural guidance. Why should you use your phase array transducer for draining a pericardium, right? You should be using your curvilinear or your linear transducer. This is a pretty sick heart. Here's an effusion, and right up here is my needle going into that sac. Do you guys have any feedback for me on this image? What's some feedback for me?
Decrease track data.
What's that?
Are you coming in from the right side?
I'm coming in from the right side, yeah. What about the image itself? How could I make this image look a lot better? Decrease the depth, right? You don't need to see anything but the most superficial border of the heart to do this. And when you decrease the depth, you're actually gonna improve the image resolution of your needle tip of the pericardial sac. And also, just use your linear transducer. This is a peristernal view. I mean, how easy would this be? I mean, it'd be like the easiest thing to do, right? I mean, it'd be much easier than a deep peripheral IV. You have this nice sac to put that needle into to drain it. Here's a patient that had a pretty big effusion. Here's a linear transducer, that guide wire going right into there to drain that effusion. And then right here, you have the post image, a lot better, right? If you have a pericardiocentesis kit, use that. If you don't happen to have that, just use a central line. Central line works really well, just leave it in there, and then you could drain it kind of PRN. If the patient reaccumulates, you already have that drain in there, you just drain it out until their blood pressure gets better, and then take your syringe out. It works really well. Now, one of the things I like doing, I know this is like an echo one, but I just want to make sure to mention that in arrests, I love putting art lines in all of my arrest patients because we're so bad at pulse checks. We are horrible at identifying if somebody has a pulse or not. I'm talking medical professionals. I've done studies on this. We do not do a good job. So in all my arrest patients, I like putting art lines because it doesn't matter what the pulse is. If that diastolic blood pressure is greater than 40 with an art line, the patient is perfusing enough, right? So you don't have to even do pulse checks if you get that art line in. This is an example of doing one in the radial artery, but for the most part, I'm actually doing a femoral artery cannulation on my coding patients. And of course, with these central lines, if you're having difficulty with access, do the IO. That's the first thing, right? If you have no IV access, do your IO. But if you need something bigger, throw in that femoral line. It's fun to do crash femoral lines, just like blind. They're fun, but bringing your ultrasound machine in there might take a few extra seconds. If you have a handheld machine, you can use the handheld machine so it's not in the way. And this actually overall, I think, decreases the amount of time that it takes me to get those cannulations, even if I have to bring the ultrasound machine in the room, because I'm much faster with the ultrasound. So I'm usually using ultrasound for my femoral lines. Now let's do a couple of quiz for pulse checks. What if somebody says, I think I feel a pulse? Call shenanigans, right? So resume compressions. Now a question, like let's say that you see this and it's been 4 seconds. Do we need to wait 10 seconds? No. No, because even if there happens to be a little pulse at some point, the patient would still have like horrible bradycardia and it still needs to resume compression. So if you see this, you do not need to wait 10 seconds. Now what's going on here? This is what ventricular tachycardia looks like on ultrasound. So ventricle just kind of doing its own crazy thing. Now, what about this one right here? There's no pulse. Do we shock or do we not shock? Why would we shock this? It's shivering. Someone said shivering. I love that. It's fibrillating. And what I usually do is I look at the valves themselves. And you see how the valves are kind of like just quivering? This is VFib. It doesn't matter what the monitor shows, this gets shocked. One of the other things that I think is helpful is to look at the bubbles in the heart. You see how the bubbles are kind of like quivering as well? This is what fine VFib looks like. Now, what if you see this and somebody says, I don't feel a pulse? What do you tell them? Shenanigans, that is correct. You call shenanigans on them and they have to leave the room, all right? So this is why this is so powerful. I am using this for the majority of my pulse checks because for me, it doesn't matter what the pulse shows. If I have a great ejection fraction, the patient has a pulse, even if they can't feel it in their fingers. This is something here that if you're not careful with, you can get confused. Would you consider this cardiac activity? I mean, but look at that right side of the heart. It's moving. It looks like the right side is contracting a little bit. The what? Yeah. Or it's the effect of BVM. So if you have somebody like pushing pretty strong pressures through that BVM, it will make the heart move like this. So just be careful. This is, I mean, honestly, like if I saw this, it would still be like so low, I would still say that there's no pulse, right? But this is a complete cardiac standstill, and this is something that can happen with the BVM. This is a good example. This is actually a post-arrest echo that I had. Now, what would you do with this? You know, like, would you resume compressions? Would you stop compressions? This is tough, right? This is a very low ejection fraction, but I don't know what the patient's baseline ejection fraction is. I don't know if this is enough to perfuse the brain. I have no idea. This is a really good example for why those art lines are so important. The art lines really are the big tiebreaker for this kind of thing. All right, does anybody have any questions? There's a lot of data. Yes, sir?
Have you ever used, so if you're trying to figure out if the RV strain is acute or chronic, do you use like CAPC or S prime to kind of help guide you?
So his question is, do you use any assessments of the systolic function of the right side of the heart, like S prime, like TAPSE? And the answer is, I'm not a huge fan of those things because I have a hard time understanding how those can differentiate between chronic and acute. That definitely tells me that the systolic function is lower, but I don't know if the systolic function is lower because of an acute process or not.
Like wall thickness too, do you ever like use that as like another marker?
Yes. So wall thickness would be another big one. So 0.5 centimeters is the cutoff. You usually do that on a subxiphoid view, or you can do that on a peritoneal view as well. If the thickness in diastole is greater than 0.5, it's more likely to be a chronic thing. I do eyeball that, but my question is, in my patient that appears to have chronic right heart enlargement, do they have a new process? That's normally the question I'm asking myself normally. I mean, measuring that thing, like I do it, but I don't usually use that in isolation to like push TPA. I need more data than that because I don't know what their baseline is. Does that make sense? I mean, if you had somebody, you echoed them a week ago and you know that they had a completely normal heart and now they have some thickness, or you know they have right heart enlargement without thickness, it's probably an acute process. Whereas if you see somebody you've never seen before, they have a kind of borderline right heart enlargement, but that wall's thickening, you can for sure use that. But I'm still going to be using that ESN. I'm still going to be using the 60-60 sign to see if it's different. And then of course, I'm getting a CT scan on all these patients. Like, of course, I'm actually getting the gold standard test to see if it is a PE, but then sometimes they're sick, you can't get them over there. There's a line to get to the CT scanner, so that's when those become a little more useful. I didn't. I left it out, but we can definitely talk about it. I have actually like a series of 2 hours of lecture on acute versus like chronic right heart. So there's a lot of data out there to look at, but it's just hard to do in a lecture where you're also talking about 4 other echo things in the course of 30 minutes. So yeah, 6069 is another one. It's just a little more complex. Any other questions?
Can I chime in?
Please.
So I will actually calculate S primes. How many of you guys have like, PE response teams at your hospital, and then you divide it into a full PE response or a modified PE response? And how many of you are also dealing with like pathways generation in Epic, where they try to standardize care using a pathway? And so part of those pathway generations are figuring out like where POCUS fits into those things. So for our PERT alerts, actually, we've discussed with our ICU and cardiology, because oftentimes for us, after hours, you're getting a first-year cardiology fellow who doesn't know how to do echo, and so we're the ones who know how to do echo. So we've started including things like TAPSE, S prime, some of the more spectrum research measurements into our focus for PE response.
So to give them more data to work with.
Exactly. Yeah.
That's great. And if anybody wants to do TAPSE or S prime, they're pretty easy calculations to do. They're pretty similar. You just use M mode for one of them and use pulse wave Doppler for the other. But we can work on all of that on the hands-on as well if you have any of those questions. Yes, sir?
Does TAPSE differentiate between acute and chronic?
I think that there's some data that says that maybe, but I don't think it does. I'm not convinced, basically. Because somebody can have systolic dysfunction of their RV and have that chronically and then come in with like an acute respiratory problem, and I don't know if that systolic dysfunction of the right heart, I don't know if that's acute or chronic. And there's some data that says yes. And also, there's data that says that just right heart enlargement in a undifferentiated patient in the emergency department, most of those patients, if they have right heart enlargement, just that by itself, it's usually a PE. It's usually a PE. I'm talking about what to do about that subset of patients that you're not sure that this is acute right heart enlargement. Like if you see like a 20-year-old that came back from a flight, they're on hormones, they have an enlarged left leg, and then they have right heart enlargement, it's a PE, right? I'm not gonna be doing all these measurements on that patient. It's a borderline patient. Great, thanks so much.
Hopefully that was helpful for at least some of you. If you have any questions, comments, or you have different ways that you do things, I would love to hear from you. You can reach out at ultrasoundpodcast@gmail.com or on Twitter at Core Ultrasound. In the meantime, make sure to check out soundandsurf.com to see about our next Sound and Surf conference. Check out the courses.coreultrasound.com website for educational CME needs, including fundamentals and question bank. Hope to hear from you soon, and happy scanning.